All right. Good morning, everybody. It's good to see all of you here. So I'm going to spend the next 20 to 30 minutes just bringing you through a rapid review on malignant central airway obstruction, in short, CAO. So today's agenda, first of all, I'm going to give you some background, and then after that, we'll move on to some pre-procedural considerations in terms of assessment and planning, followed by some management strategies in terms of therapeutic bronchoscopy, and then also to try to answer the question to stand or not to stand, and finally finish up with post-stand care. So as we all know, central airway disorders can be classified very simply into malignant and non-malignant causes. And for malignant causes, central airway disorders, they can be either obstruction or some form of fistula. And obviously, we know that the most common cause of malignant CAO is primary lung cancer, and then other possible causes include esophageal cancer, airway metastases, and sometimes primary tracheal cancer. And today we're just going to focus on malignant CAO. So what's the clinical impact of malignant CAO? So we know from data, existing data, previously it was thought that about 30% of lung cancer patients present with some form of malignant CAO, but we know from emerging data or more recent data that this is only about 13% at diagnosis. And on follow-up, about 5% of them will develop signs and symptoms of malignant CAO. And so what are the implications of malignant CAO? So obviously patients have lower survival, they have poorer quality of life, performance status, and also very importantly may jeopardize the potential for the patient to undergo systemic treatment by compromising either lung function or getting them prone to getting infections. So mechanistically speaking, I think it's very simple. Malignant CAO can be either intrinsic, intraluminal, or extrinsic from external compression, or a combination of both, which is mixed. So another way to classify malignant CAO will be anatomically. So we'll like to know the extent, the location, as well as the severity. And usually severity is a visual estimate of the cross-sectional area involved. So, as an interventional pulmonologist, we always wonder what are the benefits of therapeutic bronchoscopy in malignant CAO. So, and what's the data, right? So, in patients undergoing systemic treatment, therapeutic bronchoscopy likely improves symptoms, survival, and spirometry, which is not so important, the last one, because it's not really patient-centric. But the caveats are that in terms of survival, it appears that purely intrinsic patients, obstruction, these patients actually have better survival outcomes as compared to extrinsic or mixed. And bear in mind that these treatments must be given in combination with cancer-specific treatment. So coming to pre-procedural considerations, I cannot stress enough the importance of selecting your patients well. So patient selection is key. CAO, the patient must have CAO, but the symptoms must be largely attributable to the CAO. As we all know, patients with lung cancer have many reasons for shortness of breath, whether it's a lymphangitis, pulmonary embolism, SVCO, etc. Right? And anatomy, and that's physiologic. And anatomically, it must have more than 50% narrowing, and there must be distal airway patency beyond the obstruction, and we also have to look at the pulmonary artery function, and the patient must have some acceptable performance status at baseline. There is an important caveat why patient selection is key. And this is because there is a discrepancy between technical success and symptom improvement. So for example, in the AIRWAY registry from the United States, 93% of patients were deemed to have a very technically successful procedure, but only about half of them actually experience improvement in terms of symptoms, right? So I think we really have to bear in mind that we do not overdo, right, therapeutic procedures in this group of patients. And moving on to a more detailed pre-procedural considerations, obviously informed consent is pivotal, and then followed by a history, whether it's acute, subacute onset of bleeding, acute onset of shortness of breath, consider the comorbid conditions, C-spine involvement, antiplatelets, anticoagulants, as well as the oncologic therapies that have been given. And physical exam, basically, we just have to make sure that the patient doesn't have a difficult airway, or if patient is a potentially difficult airway, we have to make some preparation. Third will be imaging. Basically, normally would just be chest imaging, chest radiograph, as well as a CD thorax. It's important to just make sure on the CD thorax, you would like to evaluate like tumor anatomy, distal airway patency. You can also look at the PA, and also, as mentioned earlier, to look for other causes of shortness of breath. Reviewing recent studies is important because it sort of gives us a timing of the duration of the atelectasis. And also important thing is the caveat is determination of distal airway patency may not always be very reliable on CT, and therefore ideally if possible a bronchoscopic visualization with or without contrast would be ideal. If not, then at least sometimes a PET scan can help to differentiate between collapsed lung as well as tumor. And finally, logistics, I think that is a no-brainer. So we have to consider the situation under which therapeutic bronchoscopy is going to be performed, whether you're going to use a flax or rigid bronch, the sedation, the anesthetic strategies, the type of artificial airway, if you are using, if you are going for GA, and then the ventilation strategies, hemostatic therapies, and even consideration of a preemptive ECMO if needed. So the ACCP, so this is just in accordance to the ACCP Clinical Practice Guidelines, Management of CAO 2025. So for patients with suspected CAO, we recommend a comprehensive history and physical examination with a focus on the respiratory system, CT scan of the chest, and preoperative assessment. So next, we're going to talk about the therapeutic bronchoscopy in CAO. What are the procedural safety and steps? So how safe or how risky is therapeutic bronchoscopy? From the acquired registry, the mortality from complications is very low. Actually, it's only 0.5%. Complication rates are not overall are only about 4%, and 2/3 of them actually required some escalation of care. And in the CPG as well, rigid bronchoscopy is preferred, and general anesthesia, deep sedation preferred over moderate sedation. But just bear in mind, these are all conditional recommendations with very low certainty of evidence. So the management of CAO is quite basic. I mean, in terms of the steps, right? Number one, you need to secure the airway as appropriate. Number two, you need to establish the airway patency of the involved airway. And a few strategies, you can either recanalize, you ablate the tumor base and plus minus stenting, or if it's purely extrinsic, you just need to put in a stent. And third, after finishing the procedure, so if you have put the patient, under GA, and you can either extubate on table or you can keep the patient intubated and admit to the ICU. So these are the broad management principles. So I'd like to emphasize the importance of having a protocol. So this protocol is what we do in SGH because there was a case of a malignant central airway obstruction that was acute. The patient presented with stridor, but it was intrathoracic. So there was some confusion about at ER about who to call. So now we have a protocol design at ER so that the ER physician knows what to do. So either they call ENT, airway team, or if the patient has got a known tracheal bronchial pathology or suspected to have, then it will be a stat IP consult as well as anesthesia. So what are the recanalization techniques that are available? So the factors affecting the choice would be the technical demands, how urgent the central airway obstruction needs to be treated, as well as the airway anatomy. And then also you need to consider the logistic demands, resource availability. For example, sometimes even in my emergency OR, if they don't have a theater with a laser port, then I will have to use APC. Right? So the recanalization techniques can be nicely summarized, either mechanical debulking or bronchoscopic ablative therapies. So mechanical debulking, my favorite is mechanical coring because it's fast, swift, and decisive. In terms of bronchoscopic ablative therapies, they can be either immediate, have immediate effects, or delayed. And the immediate effects, the therapies can be classified either into hot or cold therapies. So the hot ones are the ones highlighted in red, right? And then cryorecanalization is the one in blue. So in terms of the delayed ones, I think some of the previous speakers have already talked a little bit about ablation as well as intratumoral chemotherapy. So I'm just going to move on. So the contraindications of bronchoscopic ablative therapies, absolute would be if it's a purely extrinsic airway compression, which is quite rare. And relative contraindications would include distal airway obstruction, atelectasis more than 4 weeks, and cannot tolerate low FiO2, especially when using hot therapies. And then if the patient is expected to pass quite soon. So this is just a summary table of the available bronchoscopic ablative therapies that we have. Right? So the hot ones are shaded in orange, and the cold ones are in blue. So there is, just want to make a distinction between cryorecanalization and cryoablation. So these are all cryo techniques, right? But cryoablation means that you just treat the tumor with series of freeze-thaw cycles, right? And then you don't really do any immediate debulking. You have to do a clean-up bronchoscopy a few days after. So the treatment is not immediate. And now moving on, talking about indications for airway stenting in central airway disorders. So in general, there are only 5 indications for airway stent in central airway disorders, right? So, and the 2 that affect malignant central airway obstruction would be for extrinsic compression from tumor or nodal metastasis, prolonged airway patency after bronchoscopic ablative therapy, and also stents can be used to treat malignant aerodigestive tract fistulas, non-malignant strictures, and also to stabilize collapsing airways, although it's not so ideal most of the time. So comparing the stents, so how do they compare in terms of silicone and metallic stents? So just to make it very simple, if you read the literature, they call it hybrid stents, whatever, but I think I'll just simplify it, silicone and metallic. And most of the time, we don't usually use purely metallic. That means purely uncovered stents. So it's either partially or completely covered metallic stents, and the material can be silicone, PTFE, etc. So in terms of affordability, I still think the stents are are expensive. And in terms of ease of deployment, I think both are easy, but the metallic is obviously easier. And in terms of removal, metallic stents are harder, although obviously the manufacturers of the covered metallic stents will tell you that, oh, actually it's pretty easy as compared to the partially covered stents, where there's an ingrowth of tissue mucosa and epithelialization. And in terms of complication rates, in the literature, the most common complications would include migration, granulation, mucostasis, and infection. And I'll discuss later, in the literature, the complication rates are similar. And also, in terms of versatility and usage and customization, I think, in my opinion, at least, silicone is a bit more versatile in terms of customization, because we can do it on the spot by suturing and obviously just customizing it ourselves, DIY. So the question is, does stent choice impact outcomes of stenting? So there is some discrepancy a bit between the WABIP guidelines as well as ACCP guidelines, which I'll talk about later. So, but in terms of benefits, we know at least that stenting may lead to improved quality of life, performance status, improved survival, and early deliberation from mechanical ventilation for respiratory failure. And therefore, in the WABIP guidelines suggest airway stenting. However, the ACCP guidelines suggest stenting only after the initial treatment has failed. So either the first bronchoscopic therapy, systemic treatment has failed, then you consider stenting. But I think it's a very complex question. So it takes into account a lot of factors. So it's a case-by-case basis, in my opinion. All right. And in terms of risk, the incidence of stent complications appear to be similar from the literature, although we know that the wide stent appears to migrate less than the straight ones, but because of the greater area of coverage, they may have more mucostasis. So the stent choice in terms of material and shape really depends on the provider factors, the operator experience, the availability of the stents, as well as patient factors like their cough strength, CAO anatomy, etc. So this is the stent armamentarium that we have in SGH. So initially, for metallic, we only had Ultraflex from Boston Scientific. And that more recently, after one of my colleagues came back from the United States, we got in the Bonner stent from Thoracen, which I find quite nifty. Because of the hook and cross design, its conformity is it appears to be better, in my opinion. And then we have the Leuven metallic Y stent, and obviously the traditional good old straight and Y silicone Dumont stents. And obviously, like I said, this is an angulated stent, which my mentor and I wrote a paper on. So most recently, we put in an angulated stent in a 13-year-old girl with very bad TB stenosis. So I'm just going to show you a video. So this was a lady with a locally advanced esophageal CA, underwent definitive concurrent chemo-RT, and then initially presented with central airway obstruction affecting the left main. So put in a straight stent, a silicone stent in the left main. And after that, she was doing well for for about a year, actually. Yeah, and then she started having complications, and there was like some distal airway obstruction, right? It didn't look really like granulation tissue, and obviously I had to exclude tumor, and therefore just now earlier, what I did was that I went in with a cryoprobe to make sure that there was no tumor, and then just balloon dilate the distal stenosis, and you could see actually Let me show you. So, and then a bit of, sorry. Yeah, a bit of laser as well. So it's actually very close to the secondary, very distal left main, almost abutting the secondary carina, right? But the issue was the PET scan and everything actually didn't show that there was tumor, and it was confirmed on histology too. So it wasn't really. Our suspicion eventually was some form of post-RT kind of stenosis, and therefore the Bonner stent was very helpful in conforming to that very tight space, and so I just managed to just interlock it with the straight silicone stent, and she's doing well. Okay, and finally, we're going to finish up with post-stent care. And once again, there's some discrepancy. So how do you manage patients after they have been stented, right? So the WABIB guidelines suggest surveillance bronchoscopies 4 to 6 weeks after stenting to detect stent-related complications, even if they are asymptomatic. But ACCP-CPG suggests either. Right, but in my clinical practice, actually, I'm more symptom-driven. And most of the time, I realize that after I've stented the patient, a lot of times they would have some form of imaging done by our oncology colleagues anyway. So I don't routinely do it at 4 to 6 weeks. I just go by symptoms. Yeah. And then also, the WABIB guideline also recommends or suggests the use of routine use of pulmonary hygiene measures. And actually in the statement, the majority of the experts consulted in the guideline use nebulized saline, which I don't use. I usually ask, after the procedure, I always get the physio and the chest physio to really just move the patient and then teach them some breathing exercises, and then to try to get them to cough. And also, sometimes if needed, then they might need some mechanical device, such as the a cappella device. And in terms of follow-up care and education, ideally, the patients should have ready access to care, and this is not just in terms of when they develop symptoms, but sometimes they may have like questions. It would be good to have a nurse to manage outpatient symptoms and queries. And the interventional pulmonologist, like once you put in the stent, like one of my mentors told me, you're married to the patient in a sense, So you have to be readily available to manage any complications from the stenting. Patients should have a stent card, especially if they come into an ER. So sometimes you'll be good. So at least if they are in extremis and they need to secure the airway with ETT, at least the ER physician would know where the stent is so that they don't worry about dislodging or causing stent migration. And finally, obviously, patient education is very important. And so this is just sort of like a summary table to tell you the difference between the WABIB guidelines for airway stenting as well as the ACCP-CPG. So just importantly, in terms of post-stenting, the WABIB guideline use routine surveillance bronchoscopy at 4 to 6 weeks, but ACCP is, you can do either approach, okay? And then post-stenting, there is also a suggestion to use pulmonary hygiene measures to reduce stent complications, but the ACCP did not make any comments on that point. Okay, and thank you very much for your time. Yeah, thank you.